Okay, gracias. Thank you, everybody. It's a big challenge to follow Dr. Halker. That was a terrific update on migraine. So going from something common to something rare, but still very important and informative, I think. For the next few minutes, I'll talk about NMO spectrum disorders and some recent advances. These are disclosures of mine which have to do with NMO, largely to do with controlled trials that are actually underway right now. I'm going to briefly describe today updated diagnostic criteria for this disease, the mechanisms of this disease, which is really one of the most exciting things about progress in this disorder and how it relates to other autoimmune diseases and multiple sclerosis. I'll argue that we know a lot more about this disease, what it is and how to treat it, than we know about MS. I don't really know what MS is. I'll talk about anti-MOG syndrome, which goes by many names, but linked by this new antibody called MOG, and then some recent therapeutic advances. This is the Grand Canyon. Some of you have probably been there. Hopefully you'll come and see it when you come to the meeting in Sedona next year. In 2015, an international group published consensus diagnostic criteria for NMO spectrum disorder. And this was a years-long effort to try to bring together all that was known about the clinical, the laboratory, the serological studies associated with the disease, and the pathology and imaging into one set of diagnostic criteria. And this paper in neurology, I think, does a reasonable job of summarizing this for clinicians. It looks complicated, and it is indeed more complex than the old diagnostic criteria that date back to 2010, but I think it's still manageable. And this is how I manage it. I break down the thinking about this disorder into neuroanatomic regions. So there's 6 areas of the central nervous system that can be affected by NMOSD. 3 of them are the most common, what we call the core presentations of the disease. That's optic neuritis, transverse myelitis, spinal cord, and the area postrema syndrome. So that's an episode, a discrete episode of persistent, prolonged hiccups, nausea, or vomiting, usually in combination, due to a lesion in the dorsal medulla, the area postrema. Then there are 3 other presentations involving other areas of the brain stem, the diencephalon, or the brain itself. And the criteria for this disease, one of the big advances of the 2015 criteria, was that now one could actually make the diagnosis of the disease with a single clinical presentation in any of these 6 regions, as long as it was accompanied by a positive test for the pathogenic antibody called AQP4-IgG or aquaporin-4 IgG, named after its target, the protein, the water channel aquaporin-4. This paper also provides a lot of information to help the clinician regarding diagnosis with assistance from imaging. And I won't go through all of this, but you can see, for example, an example here of an optic nerve lesion with enhancement of the optic nerve encompassing most of the length of the optic nerve. Some call this a longitudinally extensive lesion of the optic nerve. Another thing that's characteristic is chiasmitis, so inflammation of the optic chiasm. What's shown here are spinal cord lesions. Here's a longitudinally extensive lesion extending over more than 3 segments within the spinal cord, extending up into the brain stem with some associated enhancement. And this pattern of enhancement, this ring-like enhancement, is very strongly suggestive of demyelinating disease, common in both NMO and MS, but when seen in combination with a long lesion of the cord, usually means NMO. These are some representations of the area postrema lesions. So this is the dorsal medulla, and this is a serendipitously captured T2 signal or flare signal abnormality in the dorsal medulla. These are usually not destructive lesions. It's thought that this is probably a combination of inflammation, perhaps demyelination, and water channel dysfunction at this level. These lesions are often very transient, and it really is up to chance sometimes as to whether or not you can capture it, even when the patient is symptomatic. Here are some examples of lesions that were actually associated with gadolinium enhancement, and this is what it looks like in axial sections here. Other brainstem lesions can occur in NMO. Typically, they are periependymal. So here's examples of lesions in the pons, around the fourth ventricle, belly of the pons, the midbrain, and around the fourth ventricle in the cerebellum. And these are examples of diencephalic lesions. So lesions in the thalamus and around the hypothalamus. And they say a picture's worth 1,000 words, which is definitely true here because it is difficult to say in words all of the different patterns that can be seen in NMO spectrum disorder in the brain. Remember that it used to be thought that NMO did not affect the brain, and in fact, early diagnostic criteria required that the brain MRI scan be normal. But now we know, on the basis of the aquaporin-force serology and some other techniques, that cerebral lesions are pretty common. This is an example of a large confluent subcortical white matter lesion with so-called cloud-like enhancement. Obviously, these lesions look different than what one would see in typical multiple sclerosis. This scan here is meant to show in sagittal plane involvement of the corpus callosum. Recall that in multiple sclerosis, one has so-called Dawson's fingers with demyelinating lesions that extend perpendicular to the septocallosal surface. Here, lesions are often linear or boxcar-like and extend throughout the anteroposterior axis of the corpus callosum. Here's a long lesion involving the corticospinal tract, and here are periependymal lesions in the brain on FLAIR imaging and T1 gadolinium enhanced imaging. So just like in the brainstem, you can see periependymal lesions in the brain. Excuse me, detection of these patterns is very, very helpful, and in some cases, especially brainstem and brain, necessary to support the diagnosis. What about so-called seronegative NMO? Does it exist? Well, the panel thought it did, and worked very hard for a number of months to try to come up with diagnostic criteria that would be a balance of sensitivity and specificity in the absence of this very specific aquaporin-4 antibody. So a patient who has clinical disease affecting 2 or more of those 6 neuroanatomic regions, at least one of which is optic nerve, spinal cord, or area postrema. Those are the core lesion areas. So 2 or more regions, at least one of these 3, and if the myelitis is longitudinally extensive, and if the area postrema syndrome has a lesion that supports that that's the cause of the nausea and vomiting, then you could make this diagnosis as long as you exclude other competing diagnoses. And you can see that's more difficult to do when the antibody test is negative. So here, these additions of requiring a longitudinally extensive lesion or requiring MRI lesions that explain nausea, vomiting, and hiccups, those are meant to increase the specificity of these criteria. Can imagine how many people one might see in internal medicine clinics with nausea, vomiting, or hiccups who do not have a neurologic cause. So what have been the effects of these criteria for the past 3 years that they've been published? Well, certainly they've increased sensitivity, and they do that because there's a broader spectrum of both clinical and MRI findings that are incorporated into the criteria. So there's more confirmed cases, and you can make the diagnosis even after a single attack, especially in cases that are seropositive. It's been reassuring to see a number of studies work to validate these criteria in both children and adults. So this is a pediatric study showing that the criteria had a sensitivity of 97%, where the gold standard was clinical diagnosis by examining physicians. The 2006 criteria, on the other hand, were only 49% sensitive. So this is effectively doubling the number of patients that would have been diagnosed with NMO a decade earlier. There have been similar findings in adults. This is a Korean study showing an 85% increase in sensitivity, and this is a study from the UK showing a 76% increase. However, what's quite interesting about this UK study is that a lot of patients that were picked up in this study thought to be NMO by the clinicians, but ultimately they couldn't achieve that diagnosis still really don't have a diagnostic label. That means there's a lot of people out there who have some kind of inflammatory / demyelinating disease that we still don't really know how to classify them or what it is. Their antibody studies are negative. That includes aquaporin 4 and other antibodies. The benefits of the criteria then, besides increased sensitivity, also increased specificity, so the ability to separate NMO spectrum disorder from multiple sclerosis. Why is that important? Because many of the drugs that we use to treat MS can actually aggravate NMO spectrum disorder, so you need to avoid them. An earlier confirmed diagnosis, as I mentioned earlier, which can lead to earlier initiation of treatment. This is particularly important because patients with NMO develop disability as a result of attacks. Every time they have an attack, they typically will lose some neurologic function. Not always, but most of the time. That means that they accrue disability in a stepwise fashion, and they rarely develop a progressive form of the disease. So you can see that's very different than multiple sclerosis, where patients have relapsing disease early on. They typically get better from their attacks that are mild, and then when they get to be in their mid-40s or 50s or 60s, they develop a slowly worsening, typically myelopathy syndrome, secondary progressive MS. That happens to about 2/3 of people. Well, we think that in NMO spectrum disorder, if one can make the diagnosis early, institute the appropriate treatment, and prevent attacks, we should be able to keep people stable with no increase in impairment or disability indefinitely. And that's definitely not the case for multiple sclerosis. Despite the number of good treatments we have for relapsing disease, the greatest unmet need remains progressive MS. There are also clinical trials. So we wouldn't have thought this maybe 10 or 12 years ago, but as of 2018, there are 3 large multinational phase 3 clinical trials looking at therapeutics in this disease, and I'll come back to that in a moment. Epidemiologic studies are obviously facilitated by this as well, and we're getting a better picture of what NMO spectrum disorder looks like throughout the world. I don't have time to go into this today, but it's really changing how we think about autoimmune disease, men versus women, different ethnic groups, different world regions, and different susceptibility markers based on both genes and environment. So what's happening in this disease? How does it work? Well, although we talk about it often as an inflammatory demyelinating disease, many now argue that we should be thinking of it and classifying it as an astrocytopathy. And the reason for that is because aquaporin 4, the target antigen of this antibody, which used to be called NMO-IgG, it's found throughout the nervous system, in fact throughout the body, but in the nervous system it's particularly found on astrocytes and astrocyte end feet. And here's a nice schematic put together by colleagues at the University of Colorado who have at the center of the cartoon here the astrocyte and the number of mechanisms by which aquaporin 4 antibodies can interfere with astrocyte function or kill astrocytes. Everything from blocking water transport at the end foot itself to binding with the antigen and resulting in its internalization, which can lead later to complement-induced degranulation. Complement is one of the drivers of the inflammatory process in this disease. There's also cell-dependent cytotoxicity, opsonization, other mechanisms, but at the very center of this is the astrocyte. Demyelination does occur, but it seems to be a secondary process, a bystander process, not the primary process. So here are some selected questions that are often asked about the disease. How are the lesions initiated? We know that sometimes patients have, for example, donated blood, and then 10 or 20 years later, they've developed NMO clinically. Someone's gone back and tested their blood that sat in a freezer for decades, and it was positive for aquaporin 4 antibody. Why did it stay dormant for so long? What influences the distribution of lesions? And why are organs outside the nervous system that express aquaporin 4 not often affected? I don't have all the answers for these, but these are questions that many investigators are working on, joining clinical and laboratory forces. And here was an exciting development recently showing that another protein called GP78 is associated with blood-brain barrier disruption. And it's thought that that activation of this protein through interleukin-6 mechanisms, probably triggered by viruses, may be something that opens up the blood-brain barrier and allows the aquaporin 4 antibody to reach its antigen. So here's the astrocyte end foot. It's got aquaporin 4 on it. It's right up against the endothelium of endothelial cells that make up the blood-brain barrier. And GRP78 seems to play a major role in opening up that barrier. And potentially that's one mechanism where a dormant antibody could then become pathologic. Excuse me. Mechanisms for lesion localization. Why is it that we see these unique or signature lesional patterns in NMO? Well, again, we don't know, but people who are looking at animal models and imaging studies and correlating them with inflammatory markers and the way the antibody works at the blood-brain barrier level have implicated interplay between T cells opening the blood-brain barrier and the way that antibodies diffuse into the CNS. So this is telling us a lot, this disease is actually telling us a lot about the basic biology of the central nervous system, how the blood-brain barrier is regulated, how proteins and other substances enter the CNS, and how they move and alter cytokine milieu and inflammatory responses once they get in. It's something we know very little about. Finally, there's this interesting question about why is it that we see lesions in NMO in the brain, but other organs that express a lot of aquaporin 4 are not affected or rarely affected. And one of the answers to this might be complement regulatory proteins. So I mentioned before that activation of complement is one of the first things that happens when the aquaporin 4 antibody meets its target. And it seems that in different tissues, when one compares brain to tissues that also express a lot of aquaporin 4, like the kidney, the skeletal muscle, and the GI tract, there's a different balance of regulatory proteins involved in the complement system. Some of these tissues have little to no regulatory protein and are susceptible. Others have a high level of regulatory protein and seem to be relatively protected. So again, knowing the antigen-antibody relationship not only tells us about this disease, but is telling us a lot about mechanisms of complement-related autoimmunity relevant to many other disorders in neurology and other diseases. Okay, part 3 of 4, MOG. This place here is called Spider Rock. It's in northern Arizona. It's on a Native American Indian reservation, quite a beautiful place not many people go to. Years and years ago, there were first-generation assays against something called myelin oligodendrocyte glycoprotein, or MOG. And one of my mentors years ago told me, never believe anything you read about multiple sclerosis if it's published in the New England Journal of Medicine. And this was actually one of the examples at the time, because there were patients with a so-called clinically isolated syndrome, a first demyelinating event. And it was reported that if patients had MOG antibodies, that they were at higher risk of going on to develop MS. And nobody could replicate those results. And the reason for that, one of the reasons for that, was because these first-generation MOG assays were very nonspecific. However, things have changed. Even though many of us were skeptical about new assays about 5 years ago, the evidence has now accumulated very, very strongly that new generation MOG assays, which are highly specific, can detect CNS inflammatory demyelinating syndromes that are distinct from aquaporin 4 disease and from multiple sclerosis. In fact, if you take patients who appear to have clinical NMO but are aquaporin 4 negative, somewhere between 25 and 40% of them, depending on their clinical phenotype, will have MOG. So that's pretty exciting. Early literature using these next generation assays suggested that there were differences between this disorder and aquaporin 4 disease. For example, we know that aquaporin 4 is almost exclusively well, overwhelmingly at least, a disease of women, whereas this one is more balanced as far as its sex ratio. Initially, it was thought that it was more likely monophasic instead of relapsing, that the attacks were milder, and that there was more optic nerve involvement, lower cord, and deep gray involvement in the brain. And that's shown in these MRI scans here, lesion in the lower thoracic cord near the conus, and then these lesions in the deep gray. Well, recent studies have also shown that using these next generation assays, there are also biologic differences between these patients. So if you take a patient that has NMO spectrum disorder with aquaporin 4, and you study them during an attack and get a spinal fluid examination, you find that they've got tremendously high levels of GFAP, and that's a marker of astrocyte damage. So as I mentioned before, aquaporin 4 disease, many of us think this should be categorized as an astrocytopathy. Target, kill the astrocyte, it spills GFAP into the CSF. Well, it turns out in MOG disease, even though they look similar clinically and they have a similar phenotype radiologically, if you study them biologically, one of the main differences you see that is that in CSF, you don't see GFAP at all, but you do see myelin basic protein. And this is something you'd expect to see in a primary demyelinating disease. So very importantly, we've moved in just a few years from descriptive phenotype, that is talking about opticospinal disease and classifying patients on the way they present clinically and somewhat based on their imaging, to being able to define diseases potentially on the basis of a biomarker signature. So that's very exciting. What does the MOG look like now? There are many laboratories in the world that are doing in-house MOG assays. And there's very little in the way of MOG assay validation between centers. So, for example, collecting cases at multiple centers, sending them into one center, and seeing whether we get congruent or concordant results with each one. There's very, very little data on that. Mayo Clinic a few months ago started offering the MOG assay as a commercially available test after a very long process of validation. There are also centers in the UK, Japan, and Germany that have done something similar in-house. So we're looking to see validation studies and replication studies going forward. But so far, excuse me, what we see is that complement is important in this disease. The antibodies persist in most patients. It's actually not a monophasic disease. It usually relapses, and sometimes the disease is as severe as aquaporin 4 disease. It responds to steroids, and it responds to plasma exchange, and it seems to respond to immune suppression. So despite the marked differences in pathobiology, the treatment responses and the behavior of the disease, this is a schematic of relapsing disease over time. A scatter plot looks very much like what you'd see with aquaporin 4 disease. They seem very similar. So finally, how do we treat these patients? So the first strategy, of course, is attack prevention. As I mentioned earlier, it's critically important. Avoid MS drugs. The drugs that are almost certainly have derogatory effects in aquaporin 4 disease, at least, are beta interferons and natalizumab. The mainstays of treatment for aquaporin 4 disease are rituximab, mycophenolate, azathioprine, and corticosteroids, depending on where one lives in the world and what one has access to. I alluded to this earlier, but understanding the mechanisms and the targets that are relevant in this disease has really opened up the opportunities for therapeutic intervention. So this is a schematic put together by my colleague Brian Weinschenker in a review we wrote last year, showing that if you again focus on the astrocyte and its relationship with blood vessels, you can find many opportunities through interference with antibody binding, inhibition of complement, general immune suppression, affecting B cells, through things like pulling antibodies away with plasma exchange or interfering with antibody production, or even perhaps one of the holy grails of inducing tolerance, something that's long been a dream of immunologists, but an elusive one so far. This is a very good candidate disease to develop tolerance therapy. Future NMO therapeutic strategies may include some single or combination approaches, such as complement inhibition, B-cell depletion. So rituximab, for example, targets CD19, but there are others that more fully deplete the B-cell lineage and might be more effective. Combination therapies, stem cell therapies, inhibition or blocking of binding of the antibody. So some of the exciting ones, eculizumab, I would say, is one of the most interesting because this is a monoclonal antibody that targets complement. It interferes with the development of the complement cascade. If you remember, when that starts, it builds up this thing called the membrane attack complex, or MAC, that kills cells. So if you interfere with that process, this is truly neuroprotective. This was a study that we did at Mayo Clinic, a pilot study. You can see here patients had very active disease. Every one of these diamonds and squares and circles is an attack. Then we treated them with eculizumab for a year, and we had no confirmed attacks. Everything that occurred during that 1 year was ultimately thought to be a pseudo-exacerbation, not a true attack. We withdrew the drug, put them back on different immune therapy, and 5 patients had 8 attacks, and we thought that that probably bolstered the argument that eculizumab was helpful. This drug is now one of the drugs well along in a phase 3 trial. One can also interfere with interleukin-6, a very, very important cytokine in this disease, with an available drug called tocilizumab, and there's a form of this that's also being studied in a phase 3 trial. There's an anti-CD19 therapy called MEDI551, or inebilizumab, unpronounceable antibody name, and it depletes a wider B-cell lineage than rituximab. One of the exciting things is that it covers plasma cells, plasmablasts. These are the ones that are actually making antibodies. So if we could deplete those, we might have a more effective therapy than rituximab, which does not get at those cells. And then there's been some exciting work in case series published recently, looking again at different mechanisms. Here's a drug called bortezomib, which is a proteasome inhibitor used in treating certain types of cancers like myeloma. So it depletes long-lived plasma cells, that's why it's good for myeloma, and is an advance over anti-CD20 therapies. The results of this study, this was just a case series, were quite remarkable given the aggressive nature of the disease and the lack of response to rituximab. So in summary, the diagnostic criteria are sensitive, seem to be valid, useful both in practice and research in both children and adults. Aquaportin 4, we think, is an astrocytopathy, the mechanisms of which are opening up many avenues for therapies. MOG looks real. This looks like a real syndrome. We test for it now routinely in all of our patients in whom we're testing aquaportin 4. And it may make up a quarter or more of the so-called seronegative NMOSD cases. And we're going to get the results of some phase 3 trials within the next 1 to 2 years that are going to change the landscape very dramatically. Thank you very much for your attention. If we have time, I'm happy to answer any questions.